Good morning and welcome to our presentation on new novel psychosocial interventions. I'm Rebecca Headley. I'm a clinical social worker at the St. Luke's Cystic Fibrosis Center in Boise, Idaho, a Peds and Adult Center. My co-moderator is Natasha Emerson from UCLA.
Hi, yes, I am the psychologist for our adult program at UCLA and also run the consultation liaison service there.
Thank you. So thank you all for coming. We have a lot of really good presentations to share today from some wonderful presenters, so we're going to keep our introduction very brief. But we're excited to explore some new psychosocial interventions that are being utilized throughout the country to assist individuals with cystic fibrosis from childhood to adolescence to adulthood. We know that we are going to have some really good thought-provoking questions in the Q&A from our audience, and so we're going to leave adequate time for that. Please submit your questions through the app as we go along, or you can come up to the mic at the end of the session. We'll do a Q&A for all of the presentations together. So that's really it. Thank you for coming, and we're excited to hear from our speakers.
Hi, everybody. So it is my pleasure to introduce our first speaker, Dr. CJ Bathgate. CJ Bathgate is a health psychologist and an associate professor of medicine at National Jewish Health. She works on the adult CF team as a clinician and a researcher, and is current vice chair of the CF Foundation's Prioritizing Research in Mental Health Working Group, or PRIME for short. She'll be speaking on results from her 3-year multi-site randomized control of CALM. Please help me in welcoming CJ.
All right, I'm going to be all smiles this morning because I've been waiting for this moment for 3 years. So I'm very grateful to the foundation for funding this project from its infancy, from when it was a pilot to the randomized controlled trial that we're going to talk about today. Here's the disclosures of the authors. And so I wanted to just start out with what is CALM. So 5 years ago, I created the program CALM because at the time there was no specific evidence-based practice that targeted depression and anxiety symptoms in adults with CF. And so I had a few priorities in mind when I made CALM. Number one, I wanted to reach as many people as I could. Number two, I wanted to make something short to increase buy-in so it wouldn't be a huge time commitment for people. And number three, I wanted to focus on practical, use right now skills to deal with stress. Using an evidence-based framework of cognitive behavioral stress management, skills were tailored to adults with CF to help them better manage their daily challenges. And in this table, I've listed very generally the topics that were covered in each session. And so starting off with the first one, understanding stress management and activating our relaxation response. So if you guys were in the burnout session yesterday with Dr. Sangwan, she spoke about understanding our body map. And specifically the way that our body communicates with us to let us know that we're stressed. And so we do this with folks that enter the CALM program, trying to figure out where do you feel it in your body or your mind or your behaviors when you're starting to feel overtaxed, overstressed. Are you someone who starts canceling plans? Do you start getting that crick in your neck? Do you start, having your belly hurt? Really identifying individually for each person that comes in, how is it that they experience stress, and then teaching them how to hijack that stress response by activating one's relaxation response. We've got the classic CBT model of how thoughts impact emotions and behaviors, but then I've incorporated some things like improving communication. How do you get social support from different people in your life for different purposes? Self-care that works for you, coping skills training. This one is really important because a lot of times the thought work, you've done all the thought work and the stress is still there. So now what? So that's a module on that. And then goal setting, which is really focused on thinking through what it is that you value and what are your needs across different domains like physical, social, cognitive, and spiritual domains. So during 2019 to 2020, Calm was piloted in a group of 31 adults with mild to severe symptoms of anxiety and depression, and we found preliminary evidence that Calm reduced depression and anxiety while improving coping, vitality, and social functioning. And so this was the launching pad for the larger multi-site randomized controlled trial I get to talk to you about today. So the multi-site RCT features 6 key enhancements from the pilot study. First, the manual is updated based on participant feedback, and one of my patients actually designed the cover of this, and it's now become Calm's logo, and I'm very grateful to her for letting us use this. Second, I added a booster session 2 months after completing the 6 core Calm sessions to help maintain treatment gains. We recruited a large sample of geographically diverse participants from National Jewish Health in Denver, Johns Hopkins Medicine in Baltimore, and at the University of North Carolina in Chapel Hill. Measures of treatment fidelity and relational quality were added to ensure that study therapists were delivering the intervention as it was intended and making sure that they were establishing appropriate therapeutic rapport with their patients. And finally, we added a clinical supervision component to help with early guidance, course correction, and skill maintenance. So our goals of Calm were simple. First, we wanted to reduce depression and anxiety. Next, we wanted to reduce stress, improve the way people cope, and improve their health-related quality of life. And third, we wanted to see if we could maintain those treatment gains after the intervention completed. So to be in the study, you had to be an English-speaking adult with CF. You had to have at least mild symptoms of depression or anxiety and located in a state where your study therapist was eligible to deliver telehealth services. Exclusion criteria was anyone who reported moderate to high suicide risk, had a suicide attempt in the past 3 months, were currently enrolled in a study that was already aimed at improving mood, or if they received Calm in the pilot study. So participants that consented into Calm were randomized into receiving the intervention either immediately or they were on the wait list, which had a 13-week delay. So in the light teal color, these are survey time points. So once the groups completed their baseline surveys, the immediate group received the Calm intervention and was given surveys post-Calm and at 1 and 3 month follow-ups. They also received a booster session about 2 months after completing Calm. Participants were given about 8 weeks to work with their therapist to complete the 6 Calm sessions, and this typically looked like 45 minutes to 60 minutes per session per week. Now, if we look at the waitlist group, they completed surveys at the same time points, but since they did not receive any intervention until that 13-week delay, we're able to directly compare the immediate and the waitlist groups at pre, post, and 1 month follow-up, at which point the waitlist crosses over into the active treatment condition. Now, although it would have been nice to have a direct comparison at the 3 month follow-up for both groups, we didn't want the waitlist group who was really interested in receiving the Calm program to wait longer than 3 months for it. And if we did end up being able to have that direct comparison at 3 months, waitlist participants would have had to wait 5 months for services. And for me, that just felt like too long. So we did collect 3-month follow-up data post-intervention for everyone, though, so that allows us to pool everyone's data that received Calm and be able to measure how treatment gains were potentially maintained over time. To measure our outcomes, we used the following measures: PHQ-9, GAD-7, the Perceived Stress Scale, Coping Self-Efficacy Scale, and selected health-related quality of life domains of vitality, social functioning, and physical functioning. So let's talk about our sample and demographics and the health characteristics. So we had a total of 132 participants, 66 in each group, and there were no baseline differences between the groups. 2/3 of our sample identified as female, and while the majority identified as white and non-Hispanic, we had 9% identify as Black, biracial, or other, and 10% as Hispanic. Most participants were in their mid-30s and working full-time in some capacity, but almost a quarter of our sample was low socioeconomic status, making less than $25,000 a year. Most people in our sample identified as heterosexual. However, we had 17% identify as LGBTQIA+, and many were married or in a long-term partnership. 89% were taking a modulator. Their FEV1 was in the mid-70s, and almost a quarter of people were hospitalized in the past 6 months. And when it came to mental health support, 58% were taking a psychotropic medication at baseline, and 1 in 5 were in regular ongoing therapy. With regard to our outcomes of interest, there were no baseline differences between groups for any of our outcomes. And so let's take a closer look at our primary outcomes. We'll start with depression. So for depression, the average total score was around 9, so that's the high end of mild. And we had 41% that reported moderate to severe symptoms. Additionally, almost 10% of our sample reported suicidal ideations, and we determined that they were at low risk for suicide upon further questioning, so they were allowed to stay in the study. For anxiety, the average total score was also around 9, with 43% reporting moderate to severe anxiety symptoms. And so as you can see, we have a wide range of baseline depression and anxiety reports, which I think is a major strength of this study. Now, as we head into the results, which all use linear mixed models with intent to treat analyses, each slide has a lot of helpful information, and I'm going to present on it consistently for each construct. So I want to just orient you to what you're going to be looking at on the screen. So if you're a visual person, you can look at the graphs. If you are a word person, you can look at the words. So at the top, I'm going to list the construct, what is the measure, and its possible score range. You're going to see 2 graphs below this. The first is going to be a comparison of the wait list in the immediate groups at those time points of baseline, post, and 1-month follow-up. And then the second is going to be looking at results across time from everyone that received Calm. Down here in the bottom, I have a helpful reminder for how to interpret Cohen's d, which is effect sizes, which is really helpful to look at. And then there's going to be written text on how to interpret the graphs. Let's start with depression. Pick whichever place you'd like to look. So the orange line is the waitlist group, and the blue line is the group that received Calm immediately. This is going to be the case for every single slide from here on out. So each figure shows the mean estimates with 95% confidence intervals. So compared to the waitlist group, people in the immediate group that received Calm right away reported significantly reduced depression post-Calm and at a 1-month follow-up with medium to large effects. That's a big deal, medium to large effects, that's huge. And when we look at the minimally important difference, or the MID, that refers to the smallest change in treatment outcome that a patient would perceive as beneficial. And so those in the immediate group had 40% reach the MID at the 1-month follow-up, compared to only 20% in the waitlist group. And these treatment gains were maintained over time. When we look at anxiety, compared to the waitlist group, people in the immediate group reported significantly reduced anxiety post-Calm and at 1-month follow-up with medium effects. 40% reached the MID compared to only 16% in the waitlist group. Treatment gains were maintained over time. Next, we've got stress. So people that received Calm right away had significantly reduced stress post-Calm and at the 1-month follow-up with medium effects, and treatment gains were maintained over time. This is great. When looking at coping self-efficacy compared to the waitlist group, those that received Calm right away had significantly improved coping self-efficacy post-Calm and at the 1-month follow-up with medium effects, also maintained over time. When we look at vitality, this refers to a person's sense of well-being and their ability to engage in everyday activities. And those that were in the Calm group that immediately received it showed significantly improved vitality after Calm and at the 1-month follow-up with small effects, and their treatment gains were maintained over time. When looking at social functioning, compared to the waitlist group, we didn't find any significant improvements post-Calm or at the 1-month follow-up for those that received Calm immediately. But it is interesting to just notice the upward trend for the immediate group, which is that blue line, across time that we don't see in the waitlist group. So this suggests that the immediate group is reporting benefits in social functioning across time, but the differences were not significant. And when looking across time at the combined groups, we do see that increase in that the treatment gains that were made were maintained. Similar to what we saw with social functioning, there were no significant improvements in physical functioning between groups. But there was an upward trend seen for the immediate group, suggesting that perhaps physical functioning benefits were happening across time. So in conclusion, the big take-home message of this is that Calm significantly reduced depression, anxiety, and stress while improving coping and vitality in adults with CF with mild to severe symptoms of depression or anxiety, including those that reported suicidal ideation and were determined to be at low risk. So the inclusion for those in this study with moderate to severe symptoms is a huge strength of Calm and of particular importance because research linking TIDES data from nearly 1,000 adults with CF to US CF patient registry data found that those with a single positive screen for depression were 2 times more likely to die within 5 years compared to those that screened negative. And furthermore, when the authors adjusted for potential confounders like age group, gender, health insurance status, CFRD, the likelihood of mortality was the highest for those in the severe range of depression. So I am so happy that we now have a tailored program that we can offer to people that are reporting a variety of symptoms, and it can be helpful for them. So having this intervention inclusive of people with severe symptoms may actually extend the benefits far beyond symptom improvement in that it may reduce their chances of early mortality. Next, we saw upward trends for social and physical functional improvements, which might suggest perhaps these constructs just need a little bit more time to see a significant, meaningful change. We can't necessarily capture it within 3 months. Next, I encourage any intervention developers out there to not fear question 9 on the PHQ-9. And I've done this myself in other studies where we do the PHQ-8 because a lot of times it's easier and there's not as much reporting and all of that goes on. And Q9, for those of you that are not familiar, this really focuses on thoughts of death or hurting oneself. And although this question most definitely is a marker for suicidal ideation, we just need to ask more questions because in my experience and those of the study therapists that are in the audience, most people that endorse Q9 end up being pretty low risk for suicide, often sharing that they think a lot about death as a function of having a chronic illness, but not necessarily that they have any sort of active intent or plan to act on these thoughts. So where do we go next with this, with these wonderful results? Well, I just submitted a grant last week, and I'm so thankful I got this presentation put together in time because it was made a couple days ago. I submitted a grant for a health equity grant, which could support equitable dissemination and implementation of this program to clinicians in the US, Canada, and Europe. And I'd really like to see Calm used with different populations. So can we do this in a group format to encourage cohesion between our patients? Could we do this with adolescents? Could we do this with very specific subpopulations within our population? So people with CF-related diabetes or people undergoing lung transplant. And one thing that I'm really excited about, I've actually done this with a cognitive behavioral therapy program for insomnia, is to create an interactive, direct-to-patient electronic version. I think that the skills in here lend itself really well to that type of intervention, and I really see Calm as a stepping stone into therapy. A lot of people join the study because they're like, oh, this isn't therapy, this is just stuff I can use right now, I'm in. And then after they did Calm with their study therapist, more often than not, at the end of the session, they'd say, hey, can we keep this going? Absolutely, we can keep this going. And if for some reason one of us doesn't have room on our schedule, we will connect you with somebody in the community. And so it really opened up that choice point to have that conversation. So, because some people they're a little bit afraid of therapy. So this is a really nice way to introduce some skill building for some things that they can see right away and get some of those gains right away without having to commit too much. So I want to give a huge shout out to my absolute dream team of researchers. I love the people that I work with. I'm making eye contact with each of you that are on the slide. So if you see them, say congratulations on the hard work that they've done. And of course, the patients. They are a dream to work with as well, and we could not have done this without them. If you want more information about this, I will be at poster 542, and you can always email me about this program or collaborating or just any questions that you have. Thanks.
Thank you so much, Dr. Bathgate. That was thrilling. And yes, I'm so excited that you did not exclude the suicide question and that you're reaching people of varying severities of depression. It's really, really important. Next up, we will hear from Dr. Alexis Yetwin. Dr. Yetwin is a pediatric psychologist at CHLA, Children's Hospital Los Angeles, embedded within the pain medicine and cystic fibrosis clinics. Dr. Yetwin has almost 2 decades of experience in clinical practice and research in pediatric chronic pain and almost a decade of experience working with youth and young adults with CF. She utilizes a variety of evidence-based treatments with her patients, including CBT, DBT, and biofeedback therapy, and is currently working on projects addressing procedural anxiety and increasing social and psychological support for youth with CF through a telehealth ACT-informed group. Please join me in welcoming Dr. Yetwin.
All right. Hello, everyone. Thank you for being here. We're all really excited that so many of you showed up this morning, by the way. It makes us feel really valued. We know that psychological research is important, and yet our patients and sometimes providers don't always really understand all that we do and how we can support with chronic medical conditions. So thank you so much. So I am speaking about making new connections, an ACT-informed telehealth group for teens. And I wanted to start by giving a shout out to our amazing social worker extraordinaire, Kim Morse, who this would have not been possible without her help. So we're going to talk about that. And I'm from Children's Hospital Los Angeles. So nice to see all of you. Do I just press this one? Okay. All right. I do not have any disclosures. So the background, obviously, this is not a surprise or news to anyone. You know, adolescence is a very hard time. There are many challenges, and then you add the challenges of CF, right? So we're talking about a heavy treatment burden. The daily treatments and guidelines make it really hard, and, you know, patients that have CF cannot just like all hang out together. Which is really hard because this shared experience is so important and valuable. And we know that isolation leads to increased anxiety and depression. We also know that fortunately, like Dr. O'Hara has talked about, and I hope you guys went to that workshop that happened yesterday. It was awesome, so thank you so much. She has demonstrated with her colleagues that for adults with CF, an ACT telehealth group, not a group, but an ACT telehealth sessions can be really effective. And so in her work, she talked about how it can reduce psychological distress, increase lung function as measured by FEV1 and the FVC ratio. And then also, we know that ACT is really effective for other chronic medical conditions, but really hasn't been studied as much with adolescents with CF. And since we work at a pediatric hospital, I was really curious about how this could be utilized with our patients. Okay, so I'm going to give some background on how we arrived at the group that we have, but our objective eventually was to create this virtual ACT-informed group to increase social support among our patients. And I'm going to talk about the feasibility of implementing it at our center, program development, adaptations that we had to make, and assessment plans for further exploration. All right, so to give some background, we had an interesting trajectory or journey with this project. Kim and I started with a innovative challenge at our hospital where we were really trying to get some funds and support to do a group with our inpatients at the time. This was 2019. So this was just prior to Trikafta coming on the horizon, or coming on the scene, rather, and before the pandemic. We didn't realize what we had in store for us. So we thought, you know what, let's get all these iPads, let's do an inpatient group, it's gonna be fantastic. And then the pandemic happened, and Trikafta came out, and we saw these amazing effects of Trikafta, and we saw our census decrease, our inpatient census. So we had to kind of rethink things. And so we did this needs assessment around 2021 as things stabilized a little bit more in the pandemic. And we asked our families through SurveyMonkey and then also with a printed hard copy in our clinic, we asked them about their interest in a group. We wanted to see like, okay, well, we were thinking of an inpatient group, but would you also maybe be interested in an outpatient group? And what would you think would be helpful for? So the survey explored patients and families' interest in the group, their group interest, preference, desired outcomes, and inpatient experience as a whole. And then in 2022 through 2023, we were now starting to launch our group, and we'll talk about how we arrived at the outpatient group versus inpatient. But in terms of our methods, we sent out a flyer. We also had to figure out funding. So one of the things I'm going to talk about in terms of barriers and challenges is that we were all set to do this on the clinical side. We're like, yes, we're ready to roll. Let's have this group. But within our hospital, they were saying, oh, well, you're a psychologist and you're a provider and you're expected to bill. And so how is this really going to work? So fortunately, we are very lucky within CF at our hospital that we have a donor fund for our patients. And our donor, Mr. Wade, was really exceptional at actually saying, you know what, this sounds like it would be great for the patients and families. And so he funds my time to do the group. But we'll also talk about the challenges with continued funding. So we launched this ACT-informed telehealth group in September of 2023. And I'm going to talk about the needs assessment, the survey that we did. So 36 families completed our survey. In terms of group interest, it was kind of split. Less inpatient interest than outpatient, but it was pretty split. We also just looked at their experience in terms of inpatient time and hospitalization. So almost 2/3 had been hospitalized in the past 1 to 2 years when we did this needs assessment. And in terms of the feelings that they experienced during admission, a large portion of them felt stressed and anxious and bored. I think that's a fun word that teenagers love to say to just encompass it all. And because who wants to say that they're depressed, right? But 14% did say that they were feeling sad or depressed, and then frustrated or angry, 17%. And then 14% said lonely. And I think another important thing to point out here is we were very mindful of adding in all those different feelings into the questionnaire because, a lot of kids and adolescents do not understand, or families don't know, that depression can show up as anger, that anxiety can show up as anger too, your frustration. And so that's why we asked about it in many different ways. So we also asked, what would they be most interested in attending the inpatient group for? And so most, so a good portion didn't want to attend, which is okay. But for those that wanted to attend, they wanted to talk to other patients with CF. It was really the social component that was the big piece. They also wanted to feel less alone and isolated, and then pass the time and feel less bored. All right, so like I said, we launched, so what we decided to do is Kim and I had this discussion, and since our inpatient census was much lower, we would have like 2 patients at a time, it just didn't make sense to have an inpatient group. So we decided to do the outpatient group, and originally the group was going to be, and that's in the last column for adaptations made, the group was originally planned to be like a 6-week true sticking to ACT based psychotherapy group. But as we soon found out, that was not really what our patients wanted. So we did change things up and we switched to an open group format. This is very much in its infancy and pilot feasibility stage. So I just want to really thank you guys for letting me talk about this today, because this is not, the best research ever. This is more just sharing our experience. And I would also just encourage everyone to, think about what your patients need, what your center needs, and just try something, right? Because we don't know until we try. And as we really saw, we didn't know exactly what our patients needed until we actually started doing the group. So we have had 4 patients in total that have done it. In terms of interest, we just wanted to get things started. And so the age range was 11 to 14. Now, we'll talk about some challenges with that in a second. Half of the participants were white, and then we had one that was Latinx and one that was biracial. And we have completed a total of 24 sessions. We also found that because the social piece was so important, that we basically we aim for about a 50-50 split between social activities. So how would patients talking about their weeks and talking about, some conflict with a peer or boy issues. And then we taught, and then a 50-50 split with also the therapeutic activities. And then we also restricted the age range over time. Okay, so this is just a list of some sample interventions. And there is a reference page that will show you the different workbooks and resources that we found really valuable in terms of what we utilized. We really strive to have activities that were engaging. When you're doing a telehealth group, you need to make sure you're going to have these patients involved and wanting to do it. So easy activities like grab a snack and do mindful eating was very helpful. That was something easy to do. Oftentimes they would have a drink with them. They also all loved art. That was a big thing that we found out right away. So we incorporated a lot of art-based activities, which is actually not on the slide, but just to let you know, that was something we also found was huge with our population. And so we would also try to make the art activities more interactive. So growing my garden, that was a nice way of them to kind of draw a flower and put their values on there, and then also to talk about committed action towards those values. And it was really just awesome also for them to share their artwork with their peers and their interests and talents. So just a quick sample of some of the things that we did. So challenges, as I mentioned, funding. So like I said, it was really nice that we have this donor fund and they gave us some funding, but that is ongoing, right? We have to constantly figure out the funding and the billing and insurance and all of that. So just something to keep in mind that I think I probably was not as mindful about that I should have been. So just if you're thinking of doing something similar at your center. Extracurricular schedules, we're really happy that our patients are very busy and doing all these things. It can be really challenging though to figure out what's the right time. So that was something that we ran into. This one was kind of a fun one. So navigating the level of appropriateness with content while encouraging open dialogue. We had one participant that I absolutely adore who is very open, unfiltered. And you want to encourage that, right? But also, we really have to find that balance between, what's appropriate and where all the other participants are at, and figuring out what language is okay, and then also how can we kind of guide things. So that was a fun challenge. And then developmental versus chronological age. So as I mentioned, the range was 11 to 14. Our youngest participant, who was 11, developmentally skewed actually even younger than that, but we didn't fully know that until they were in the group. So that, was a challenge that we found, but it just kind of worked out. They had another activity to do, and so then the group actually was more restricted in age, and all of the participants were around the same age, like 13, 14, and then we really saw a nice bonding that occurred. Let's see. So we have demonstrated that it is feasible to implement a virtual ACT-informed group. We had strong engagement by our patients. We still do, and we have a lot of interest. We also, this is, like I said, very much in its infancy. We haven't had a ton of participants, but that's also because we really have to sit there and take the time to recruit, figure out scheduling and all of that. So obviously our goal is definitely to increase the number of participants that we have in our group. And so this is just a quote from one of our participants about the group. She said it was a good way to talk to people your age without judgment and to talk to them about CF issues. And I have to say one of the highlights was really watching our patients engage with each other. And yes, we did talk about CF, and we definitely had activities that were focused on CF, but we also didn't talk about CF for a good portion of groups. And it was really kind of nice to see, and it was fun to hear them talk about, challenges with boys or, with their friends, and have that piece happening as well. So future directions, we definitely want to expand our recruitment. We want to look at implementing outcome measures for our group and actually seeing the effects, not just observing them. And then some other ideas that we have had is doing qualitative interviews with our participants to explore the efficacy of this group and really in more of a research-based way. And references, so thank you guys so much.
Thank you so much, Dr. Yetwin. I love that you pivoted to what teens wanted and actually stayed patient-centered. That's so important to actually have research that is clinically informed and just generalizable to the real world. Okay, next we will hear from Randy Lubin. Randy is a licensed clinical social worker in the Tucson Banner Pediatric and Adult CF clinics. She has been with the Tucson CF Centers since 2018. She is also on the social work faculty for the University of Arizona's Pediatric Pulmonary Center. In addition, she is the founder of Generational Counseling, LLC in Tucson, Arizona. Please join me in welcoming Randy.
Thank you. It's so nice to see old faces and new faces. All right, so the things that I'm going to say may or may not align with NACFC, and I have no disclosures. So here's our goal for today. In 15 minutes, I'm going to tell the background. I'm going to tell you what we did at our clinic and the results we got, and then some conclusions. And we're talking about pediatric anxiety, procedural anxiety. So we all know that a pandemic happened and changed everything. So the way that we were functioning in clinic pre-pandemic didn't work post-pandemic. We noticed that a lot of our children were coming back and the procedural anxiety that they were demonstrating was much higher, which kind of makes sense because they had a whole year of no shots, no swabs in our clinics and minimal hospitalizations, right? Like things were good. So when they came back and they had to experience those things again, we saw such an increase in that anxiety and the behaviors that were happening. And it was really hard to get those swabs and to do shots with our children. And so we're like, all right, we got to think of something. So we initially did our needs assessment and we noticed, okay, it's like kids 2 through 8. That's our main population that we're really going to focus on. And so we started doing some interventions, and then we noticed actually we're missing kids. And so we broadened it to 12 because kids that I thought were good, that maybe pre-pandemic were good, weren't good anymore. They had that break and the anxiety was back. And so we did our needs assessment, we developed some interventions, and the main thing that I'm gonna get to, the novel intervention idea, is the whole team got on board. So for my social workers and psychologists out there, the weight had been distributed of this intervention. But that's the only way that we've actually seen progress and growth in the reduction of the anxiety is it's not just one person going in and trying to do these interventions. The whole team is talking about it. The whole team is doing it. So it's been so great. And to help it, on top of that, we don't actually have child life embedded in our clinic, but we have it at the hospital. And so they did a virtual training for us as well to try to help everyone on the team really understand why this is so important and how we can work together as a team to do these interventions. And I was listening to Dr. Quittner's talk yesterday about her GEMS, and I was like, 90% of adults with procedural anxiety, we're gonna help with that. Right? I was like, that's a bummer, but it lets me know we're on the right track. So I'm old school. I use an Excel spreadsheet for my data tracking. Our psychologist is really great with REDCap, and she'll probably help me put data in. But for right now, I use an Excel spreadsheet, and I track who's coming to clinic, and then I track what happened, like, did we agenda set? Who decided, like, who's going to do the intervention? When the intervention was done? What happened? How long they cried afterwards? If they cried, how long they cried? And then if I did a teaching with the parents as well, or who did the teaching, if that was done. Okay, so I'm keeping track of all these little pieces of data, and you'll see my little step sheet of how we've kind of like come to these things that needed to get worked out. We also use a lot of PDSA cycles, and I'll show you a little snippet of that. The other thing that we developed was a post survey. And so after an intervention was done, especially if it was like a very specific intervention, which I'll talk about later, we gave the parents and then the child just a 5-question questionnaire. Was this helpful? How long, how hard, if you had to hold your child, how hard did you have to hold them? Was it a light hold? And then for the kid, they can circle anywhere on it's a face scale, you'll see it. How hard was this? So we wanted to get just their feedback as well, because having that interaction and that feedback really helped to guide us, like, is this working? Should we do this intervention again? Should we not? I got some really great feedback that things did not work. So that was helpful. So this is just an example of our PDSA cycle. We have clinic every 2 weeks, so twice a month in our PED side. So we'd come back, we'd talk about the data. We have QI meetings every week. And so we started to have to, like, what do you call it? I don't know, the accountability. The accountability was there every week where it was like, Randy, show me the PDSA cycles. Show me the data. So we had to do these every week to say, like, okay, great, this is what happened. Who was responsible identifying the child during the huddle, right? So usually if I was in clinic, that would be me. So we have these pre-huddles and we're like, okay, we have everyone on the board. Who needs a procedural anxiety, at least question today? They might not have needed an intervention, and I'll get to that point in a second, but we're at least asking. And this is where I discovered I missed some kids because I assumed that they were good, right? In that range that I was talking about. And so it was times like this where I was like, oh, there was someone who demonstrated some anxiety and I had missed them. So this PDSA cycle really helped to broaden, and so that way I could hit a wider population. So here is that post-intervention survey. You can interchange shot for swab or whatever other procedural anxiety invoking thing is happening to them. So it's real simple, and they can circle it, and the feedback, like I said, has been very helpful. Some families were like, this was so great, thank you so much, let's keep doing this. Some families were like, I don't know, and some families were like, this is not working. It was like, noted, next, we'll try something else, right? And then having the child also ask, which one is most how you felt when you got your swab or your poke? It's actually surprising. Most of the kids have been circling in the middle or even in the green. They're like, it wasn't that bad, right? So when they really think about it, sometimes it's not that bad. So this is something that we are starting to try to implement more. As you know, clinics can be chaotic, right? And so sometimes this post survey does not get done. Full disclosure, there's a lot to do. So this is something that I'll probably have a PDSA cycle about to try to incorporate that into clinic more. So here's where things have been going. So we started with our needs assessment and found that this was needed. And then one of my social work trainees developed a tip sheet. So a couple years ago, I presented it here, actually. And so I'll show you again briefly, but that tip sheet was for parents. So where we started wasn't actually in clinic, it was with parents, right? And so helping parents prepare for clinic. So that was where we started. And then we moved those interventions into clinic. What are we as a team doing? So we did our pre-clinic huddle discussion, like I said, where we're identifying which patient we're gonna ask And then how that actually looked is our family partner, who's sitting in the front row right here, would go in and she would do agenda setting. So use your PEP skills, go do your agenda setting, woo. And then she would ask the families, would you like assistance with this procedure today, with your swab or your shot? If they say yes, then she would talk about what has worked in the past, what hasn't worked, and then she would get that data. When in the clinic visit do you want this to happen, right? Sometimes waiting until the end of the visit is not helpful, right? Especially if you have kids that want to eat and you want to get that swab done. So doing it first thing might be more helpful. Or vice versa, let's say they had a hard time getting vitals, right? And so you've got a kid who's really worked up, vitals were really hard, they come into the room, they're already crying, and then the first thing that comes in and happens is a swab comes down their throat. I don't want to do that either. So maybe we do need to push it back a little bit and give them time to readjust and actually give maybe me time to go in and work with them a little bit and prep them, okay? So that is also an intervention. I think sometimes we forget about that piece of things. The other thing is who's going to do it? Not everyone likes, Dr. So-and-so and coming and doing it, right? Maybe that's more traumatic. And so what we found is that by training multiple people on the team to do some of these interventions and then also swabs and shots or getting various people has helped reduce some of the anxiety because sometimes the person themselves are triggering. So giving your patients that choice as well is really helpful. And making sure that everyone's egos are in check on the team. It doesn't matter who does it as long as it gets done. And we haven't traumatized the child along the way. And then going from here, we're still working on what interventions we're choosing to do. So I'm going to show you those. But this was kind of our step-by-step process of how we got to where we are. So the intervention tips, things to consider, some of these we've already talked about, but like I said, the parental interventions, starting with the parents. If your parent is anxious, your kids are anxious. If your parents are so afraid that this procedure is going to go poorly, it kind of does sometimes. It's very rare that you have a parent that comes in that's really anxious about how it's going to go for their kid and doesn't want their kid to cry. And then the kid's like, Mom, I got this, right? They're like little sponges. So it's really helpful if we can help the parents with their anxiety. And then we talk about modifying the request in the room, right? If you ask, can I give you a swab today? And the kid says, no, you've just set yourself up for failure. So we're really trying to change the language that's used in clinic and who's talking, right? Sometimes I have parents, to the best of their ability, are trying to be helpful, but they're just making things worse. And they keep giving too many directives or too many commands or too many requests, right? And so they're making it overwhelming over in the room. So try to give just two choices. Would you like the swab to happen on mom's lap or on the exam table? Would you like me to hold your hand or would you like mom to hold your hand? Right? You're giving them the choice. The choice is not, do you want the swab or not? The choice is, where do you want it to happen and what's going to help you feel comfortable? Okay. And you're giving, like I said, those directives of what you want to happen. And then we also use positive behavior supports. So that is included in Otter Pops, lollipops, stickers, praise, all of the good things, toys. And the whole team, we don't have any cool funding for these things. I wish we did, but the team just chips in and we all, it's, so-and-so's turn to buy the Otter Pops this week or something. So we all just chip in and get them for the kids, but they love them. Right? And so that's something else that's an intervention. You actually walk into the room with that reward because we want immediate gratification for the desired behavior that we've seen. So keep that in mind. Is sometimes if you have to go get the toy, right, we've put too much time in rewarding the behavior we want to see. So if you can go in with it, if they don't do it, let's say they have a meltdown and it just doesn't happen, and the behavior that you want to see where they did the swab easily and they didn't need to be restrained, right, then they don't always get it. And that's just part of the positive behavior support model. So sorry, guys. This is what the tip sheet looks like, and it's in 3 parts. And so this is for the parents, right? How to help your child have a smooth visit, helping them understand how to prep them. I also do like medical play. So I found these really cute like doctor's kits at the dollar store. And I give them out to families and I say, play doctor at home, right? I even have some like pens that look like little syringes that we've given out to our families. And I say, I want you to do some exposure play therapy at home with your kids. I want you to make this something fun and so it's not scary. And so you're gonna, have them pretend to give you shots, pretend to give you swabs. I go, please don't let them really stick things down your throat. That's not a good idea. But you can pretend, right? Oh, you're gonna do it. And I go, and don't be like, woo, it's great. Be like, oh no, I'm scared. What do I do? Right? Like, I want you to kind of model how it's gonna be for them, but then also model the coping skill. So I will tell you, praise, a family said that they've been doing this and that it's working. I was like, yes, it is, right? It's so amazing. Thank you for doing what I've asked you to do. So the next period is during the visit. I've really tried to encourage families, and our whole team has, to bring a clinic bag, right? Something that has things specific for clinic. And I've talked with them about, sometimes families like to use iPads and shows, and I'm like, that's totally fine. However, if you could pick one show that is just a clinic show, right? So, I don't know, Miss Rachel. Miss Rachel is only watched in clinic after the intervention and after the procedure is done, right? As a reward. So that way, again, they're starting to associate clinic with some of these things that they really enjoy, right? But they only get at clinic, because if they have access to it all the time, it's not meaningful anymore. So this is during the visit and how to be comforting. After the visit, we talk about celebrating, right? You did such a good job. Reminding your child why this is important, right? You're gonna feel so much better. You're really doing such a good job at managing your care and being a partner in your care. So great. And then, like I said, choosing to give them stickers or things as a reward for their visit. So this is just a tip sheet that we gave out, that we can give out to our families. How am I doing? So last year, I met a child life specialist who says that they use this little mouth thing. And so he's super cute. We got a couple. We named him Carl. And so he does not have teeth. That's Play-Doh. But it's just a plastic mouth. And so what we do is I take in a tongue depressor and a Q-tip and a marker, like a dry erase marker, which I will tell you, trying to clean dry erase out of his teeth is really hard, but I do it. And so we go in and I model what's gonna happen with Carl, right? Okay, we're gonna count it down and Carl's gonna open his mouth and we're gonna swab him, okay. And then Carl's gonna cough afterwards, okay, we're okay. And then I play with the kid and then the kid swabs Carl. And then I leave the marker and I say, you have a good time and you get all up in there in Carl's mouth with that marker. Have fun, right? And then I leave the room. So that way, again, he can just kind of keep playing. It's something fun. It's going down Carl's mouth. That marker goes way down in his throat. And so that's how we use him. But there's so many other things that we do because not just one intervention is going to work. And I think that's the key. And a lot of families sometimes come and they say, well, that one intervention that you tried didn't work and we don't want to do this anymore. I'm like, oh, hold on, I got a lot more, right? I can keep going. And if we have time, I don't know, you tell me, we'll do a roller coaster. It'll wake you up. These are some things that we do for needles. So we use 3D goggles. These things are $8 on Amazon. And so you just fold it up, you put it together, and then they can slip their phone in the back and watch a show as they're getting any shots or pokes. We use the party blower, so if they're scared, they can put the party blower in their mouth and they just hold it in there, and so that way when they get really scared, they can just blow really hard while they're getting their shots. This obviously you can't have a party blower in your mouth for a swab, so this is for shots only. But I will tell you that we also use it for PFT prep and play and getting them used to blowing. Busy bees, everyone knows busy bees, party blowers. Pinwheels are similar, and then we use superhero models as well. So we talked about a lot of these, but just a friendly reminder, behavioral interventions to consider. We don't apologize for what's going to happen. We are giving directives and we're being supportive. We're giving choices. We want to help parents not bribe their children to do the things that they're asking them to do. And like I said, we're using exposure play and discrete trial training to get them used to the things. What I have noticed, unofficial data, is that after about 4 sessions, the anxiety is significantly reduced. So the results that we've seen is it's improved team communication and participation. Like I said, everyone on the team is on board with this, and that's taken several years, so it doesn't happen overnight, but we've been very consistent in trying to make this something that's important. Improved parental engagement. Our parents are part of this process now as well. They're doing the play at home. They're helping prepare the bags. We also have reduced parental anxiety regarding these procedures. I've heard that when they need to go get labs externally, it's helping the parents and the kids there as well. And the parents are less anxious about how these are going to go because they know what to do and they know how to be helpful. It's also increased procedural anxiety skill acquisition amongst our children and reduced patient procedural anxiety. These are my references. Thank you to my team. And if I have a second, can I do it? Okay. So we're gonna do one of my favorite ones. I actually just discovered this, and it's gonna help wake you up for the other guys. So you're just gonna have to step out of your comfort zone. But we're modeling to the kids what we want them to do, right? So we're all gonna do it together. All right, so you are my patient. So I'm telling you, hey, guess what? Have you ever been on a roller coaster? Isn't it so fun? Oh my goodness. All right, so when you go on a roller coaster, what do? Right? You throw your hands up, you go, woo! Right? So that's what we're gonna do. Mom, I'm gonna need you to help too. You gotta participate along with it. So when it's time to go, you're gonna go ahead and help your kid throw up their arms, because I need them to hold their arms so they don't grab the swab out of their throat. So I need them to hold up their arms, woo! And then we're all gonna do it together. So on the count of 3, we're gonna throw up our arms and woo. All right, ready? 1, 2, 3, woo! Good job, you just got a swab.
Thank you, Randy. I really wish we had captured that. That was amazing. I will also say that as both a parent and a provider, I know these strategies work and they're amazing. And it's so fun to see kids build their self-efficacy and feel proud of themselves. So awesome. Next up, we have Dr. Stephanie Foligno. She is a psychologist embedded into the CF care team at Cincinnati Children's Hospital since 2009. She is professor of pediatrics at the University of Cincinnati College of Medicine, co-director of Cincinnati Children's CF Behavioral Health Program, and member of the Education and Training Work Group through the CFF Mental Health Advisory Committee. She was recently awardee for the Caroline and Richard Mattingly Leadership in Mental Health Care Award from the CF Foundation in 2020, and her research examines the psychosocial risk factors in CF, school success in CF, adherence and quality of life in CF, mental health promotion, and behavioral nutrition treatments to promote growth in CF and obesity. Please join me in welcoming Dr. Foligno.
Yeah, I'm just going to start with echoing how fun it is to look out and see this room full and see the relationships that we've built with each other over the years. It makes it so much easier being up here. So thank you to our co-chairs for the invitation. I am really I'm the person who submitted our abstract, okay? But I am representing our whole power team who created this toolkit. And hopefully, if you haven't seen the toolkit yet, you will be able to scan the QR code that is coming. While the brilliant scientists, research participants are racing for a cure, everybody in this room probably are having the boots on the ground experience that there's a lot of life being lived from the point till we get to that cure. And school functioning is absolutely essential. It is the playground for kids, hours and hours of the day. You know, when we have rough days at work, it affects us tremendously. We all know adulting is hard, and part of being an effective adult is learning how to be an effective student. We all know what the Sunday scaries are. Kids have them too. And so whatever we can do to help kids really feel good about going to school and doing well in school so that they feel like they can be successful moving out and transitioning out of that school space into a vocational and career and educational space is really important. So that is what we're hoping to talk about in terms of innovation today. Here are my disclosures. So I am presenting on behalf of our dream team here. Dr. Michelle Gelman and I co-direct our behavioral health program within our CF Center. We have Sarah Strong, who is our school specialist. We have Marissa Taylor, who is just a dream, a total dream, within the CF Foundation, a fantastic partner. And then Matt Wackler is our program manager for our behavioral health program, and he is just a whiz at basically anything you ask him to do. So talented. So this really is coming from a health equity lens. We want to make sure that people are getting the highest quality education in a safe place. We know that's an immensely important social determinant of health factor. And as we're seeing, you know, the age climb in that graph, we're very, very happy about that. We want to make sure that we are doing what we can educationally to promote health literacy, quality of life, and eventually we know how essential financial stability is. And we don't want people living paycheck to paycheck and being overburdened with medical debt and being able to go on vacations and care for a pet, whatever it is that they want to do in their adult life, grow a family. And education is such an essential predictor of being able to do these things meaningfully in adult life. What we've found through some of our work is that, and this is no surprise, probably that's why partly you're here and I'm here, is that these busy clinics, we don't have time always, we don't always have the resources that we need to have like at our fingertips to be able to guide our discussions with families. We are here today to deliver you something that is directly at your fingertips. So we've all likely seen this graph. I thank Marissa for this and pulling this from the registry, but this is just a demonstration that we have a lot of pediatric patients who are now going to be moving in to that blue section soon. And so early intervention, proactive and planned interventions are going to be really important. Here's some data for us to be thinking about is we actually, now this is a judgment-free, these are just the facts, right? We have people with CF who are graduating in their like 20s and 21s. They're delaying graduation. We don't exactly know why. We don't know that that's necessarily a bad thing. But we do see that we're having people graduate from high school in their early 20s, but that trend is sort of changing a little bit. So we are having more people graduating in their like late teens. Now, part of this also, we know that during the pandemic, high schools were just pushing people through, even if they hadn't really met the course requirements. We are here to just really bang the drum on school is a social determinant of health factor that we should really be paying attention to. This also comes from the registry. We are not saying that an ideal state would be that we see the percentages of these pie graphs shift a certain way, because this is a decision that is made by each and every person. We may not see that the bachelor level education, the master's level education is going to change. That's okay, as long as people are choosing the path that they want to choose. But what we would like to see is that we have more people, really, we know this is a predictor, that they are getting that high school diploma or equivalent. That is a portion of the pie that we would really like to see shift. So our project team did an environmental scan. We reviewed 75 plus resources that included things that existed already within the foundation, websites from governmental agencies, pharmaceutical companies, and other disease organizations like the American Diabetes Association, epilepsy, sickle cell, those sorts of things. And what we found after that environmental scan was that we had a real gap in terms of things that were specific to the unique needs of students with CF, that were school focused, and that also had, which is really important, to have some of that current legislation around education rules and laws. So we created a toolkit for all of us to use to support and guide conversations with people with CF and their families about school and targeted resources. And the school, the toolkit content is aligned with some of the care team needs that we identified in that national survey that probably a lot of you in this room completed. We thank you for that. The results of that survey are published. And what we found in that published study was that we actually got, thank you, a really nice distribution. We had almost half of our registered in the registry, the pediatric CF centers that completed the survey. 88% of those centers indicated that social workers were primarily responsible for addressing school concerns. We love our social workers. Shout out Jamie Miller. Care teams often are, so we have to be ready for this. We know this is coming. School forms, they're coaching families to communicate with schools. Not only are families needing to use the medical vernacular in their medical settings, but there's also a whole different language that exists in these school settings that they need to be coached to be able to use effectively. Teams are communicating with schools directly. Sarah Strong mentioned in her special class talk on Wednesday the importance that we all have school releases when we're doing these things. And then teams are being asked to help develop educational plans, whether that's a 504 IEP or other health plan. We all need, almost 94% of care teams said we need more materials to share with families and schools. Big gap, it's a vacancy. We need to be specifically educated on what are the school concerns that families are having and how do we specifically address those concerns. We all kind of, from an efficiency standpoint, like need things handed to us on a silver platter, and that's what we're trying to do for you all. More than half of the care team members who completed the survey said that they would really like additional staff to do and address these education-related issues, and particularly would like someone, at least in a consultative role, that has experience in educational plan development, because there are a lot of nuances to this. And you can see the results of that paper. That's the citation there at the bottom. So if you raise your hand, who's seen this CF in school toolkit? Okay, well, I'm really excited to deliver this to you. So this is just a snapshot. The layout of this is really important for all of us to understand. It was like a very intentional design. This is not meant to be read like a book. It is meant to be, I need this, boom, I go right to it. And that's why we created the table of contents. And if you actually did choose to read it from start to finish, you would see a lot of repetition. That's intentional because we're assuming that you're just going to the section that you need, and we didn't want anything to be missing from that section. So there's a lot of information about accommodations, how to educate school staff, infection control, career planning. I will say, caveat, this is designed for K through 12. There are some efforts that are underway to do more of the post-secondary. So we want to know,
I'm afraid that's beyond my abilities.
Thank you, thank you. Oh. Truth. We had 11 pediatric programs who partnered with us to pilot the toolkit, not when it was final, but when it was near final, so that we could incorporate their feedback into our final version for about 5 months. Thank you to our centers, and I'll note who they are in just a little bit because we have such appreciation for the feedback. We had some red cap surveys, we had group meetings with guided questions to say, how did you use it? What barriers were you running into? What needs to change? We had some pre-post pilot around comfort and addressing school needs. Do you have the resources that you need? And do you have the education and training that you need? You'll see this coming up here. And then we use feedback to update and improve the toolkit. So here were some of the questions that we asked. Here's the pre-post, the pre-pilot responses, sorry. So the purple is the lowest recorded score, the green is the highest recorded score, and then we have the median. So before utilizing the toolkit, this is where people were feeling the most and the least amount of comfort. What do I do when I'm fielding questions that families have about school? Do you have appropriate education and training? And here's the post response. So we see some really nice improvement across a lot of these areas. Here are our pilot centers. And so in conclusion, we designed this to be feasible, accessible, to be comprehensive, and to fill a real vacancy that we all identify as important. It's up to date right now. Everything is gonna need some improvement over time, but it has things that we found to be relevant, our pilot centers found to be relevant. And like anything, this is meant to just help us in these busy clinics have what we need at our fingertips and also guide conversations. What questions should we be asking our families? Our pilot centers reported that the toolkit did indeed prepare them to better address school needs. And we all want to be more effective in our roles. It is meant to complement state and district level nuances. We know that school districts are different, states are different, public versus private settings are different, and it's meant to complement some of these nuances and individual needs and circumstances. But hopefully this gets us started enough to know what might be the nuances that need to be addressed. And we seek continued feedback from anyone who is using the toolkit. We want it to remain practical, right at your fingertips, effective in what you need, and current. And so if you utilize the toolkit and you say, hey, someone asked me about this and this doesn't exist in here, please email the email that's listed here. Thank you, Marissa. And then here is the QR code directly linked to the toolkit. It will take you to my CFF. That should be mycff.org. Whoops, sorry. And then you'll need your login. So thank you to our research team collaborators, the CFF, for funding that has supported the development of the toolkit, as well as we've had a lot of collaboration with various members of the foundation, including the SDOH toolkit collaborators, and then of course always the families who teach us so very much about what's needed. And if you want to see more, we have a poster 555 in the exhibition hall.
Thank you so much. I know that I am really excited to get these children pumped up, especially in the age of Trikafta, now that our children can actually set long-term goals and go to college and plan for a full life. So I think it's super important. Thank you again. Now, last but not least, we will hear from Dr. Megan Marsak. Dr. Marsak is a pediatric psychologist, tenured associate professor, and division chief of psychology in the Department of Pediatrics at the University of Kentucky. She serves as the associate director for the Center for Pediatric Traumatic Stress. Dr. Marsak is a leader in the field of pediatric medical traumatic stress, having published approximately 70 academic articles, 12 chapters, blogs in Psychology Today, and a book for parents to help support their children through medical care and care for themselves, which is titled Afraid of the Doctor, Every Parent's Guide to Preventing and Managing Medical Trauma. She is also the CEO of the Sealy Coping Company, a company with the mission of making medical care better for children and their families. Please join me in welcoming Dr. Marsak.
All right. Thank you for joining all of us here today. This has been some fantastic presentations I've been able to really enjoy. So bonus, it's always awesome when you're part of a panel and then you get to see everyone else's work that you're interested in. So it's been wonderful. So this project is a multi-site study with lots and lots of partners as well. So I just want to acknowledge some of our partners here also. We have a multi-site study with the Children's Hospital of Philadelphia and University of Kentucky. I also want to acknowledge my children who are tolerating being here beautifully today as well. They're in the front. You've heard no noises, so we're doing wonderful as well. So they are joining me on this journey also. My disclosures are listed right there as well. We do have a CFF pilot grant to support this work, and then the company and the book also. So this presentation is focused on medical traumatic stress. And so I think this is a growing area of interest for the CF community and foundation, and something we're really excited to be able to provide some more data on. And so thinking about what is medical traumatic stress, what does that look like? The big fancy definition there is thinking about that physiological and psychological reactions, both to diagnoses, to things like pain, different procedures, all of those things, those emotional and body reactions that we sometimes have in context of medical care with our kiddos and adults as well. Can be siblings and families also. But the things that I kind of like to just capture it in a more simplistic way is those emotional reactions that we have to scary medical stuff. And again, that could be for the identified, in this case, we're talking about children in this study, child, it can be for siblings, grandparents, parents, caregivers, so it can kind of go beyond and affect the whole family. So we're focusing on this in this presentation today. And thinking a little bit about what does that look like? So when we think about medical traumatic stress, it can be broad. We think about it as symptoms of post-traumatic stress disorder. So things like re-experiencing, having different moments of your care popping into your mind, having alterations in mood or cognition. So that can include some of the anxiety and depression symptoms that we know have popped positive and we're screening for routinely with our CF community. Things like avoidance, trying to block it out, One of the things that we've learned from avoidance, particularly of our teenagers, is sometimes what we see as non-compliance can also be symptoms of avoidance. We've had some teens share with us that they avoid their medical treatment because it reminds them of that they're different and reminds them that they have CF. And actually doing like their vest treatments or doing their breathing treatments actually triggers their trauma reactions in the moment. Things like increased arousal, and this can be really important if we are having things like hypervigilance and increased arousal at medical appointments. You can have inflated blood pressure and vitals that actually don't reflect what is generally going on in somebody's body. So really thinking about these in context of CF care. So thinking about this a little bit more specific to CF again, some of the thoughts that they might have might be intrusive about CF, unwanted memories, unwanted treatment ideas that are popping back in. Just kind of thinking about CF when they don't want to be thinking about CF. The avoidance components, what we hear a lot is, I just want to be normal. I just want to live a normal life, especially in our teenagers. Other things I think we already talked about, with increased arousal, we'll have elevated vitals sometimes. Sometimes this comes out as sleep difficulties or increased irritability if their body just is kind of in that hyper-aroused state. And then we do have some other things that have popped out specific to CF, some of the alterations in the cognition or mood, thinking about kind of that survivor guilt. So sometimes people experience loss of other people in the community, or sometimes we'll have siblings with CF, and one sibling's presentation is really, really intense, and the other sibling's presentation, they are living a more kind of normal-ish life. So some of that guilt can pop out in those ways as well. We see this in parents too, and you can imagine and apply this to our parents and caregivers and the guilt that pops out for our parents and caregivers also. And then, I think there's been some other presentations here as well that have commented on particularly medical traumatic stress in adults with CF, and our rates are fairly high, fairly significant. We know in most of the research that we've done, it's been looked at either older adolescents or young adults, but the estimates are around 30% reporting significant symptoms of medical traumatic stress. And then with another 55%, so at least half people can identify a time where they experience some kind of procedure or some kind of medical event within the context of their CF care that they experienced as traumatic themselves. So things that our community is really facing on a regular basis. Different pieces of what does that look like in folks with CF. They've identified things that as potentially traumatic, like that loss of agency, loss of control. So that uncontrollability and unpredictability can be really challenging. Threats of bodily harm, shifts in identity. So one of the things that emerged in some of the research as Trikafta came on the horizon is for some folks that's totally shifted the trajectory of their identity and their life, and sometimes in a very positive way, but still in a big life-shifting way that they weren't planning for that. And so we've seen some of that work, people actually have experiencing that as traumatic, even if it's positive in the end, potentially. One of the things that we don't have yet is we have very little data on what does medical traumatic stress look like for youth with CF, and we don't have any currently evidence-based treatments specifically for medical traumatic stress. Some of the other interventions out there that we might be able to adapt and kind of pull over to the community, there's the Celly coping kit, and that's again like CBT based, has very specific coping strategies associated with specific presenting stressors, and that intervention we have for kids with cancer, sickle cell disease, food allergy, among a number of other disorders. Then eSkip is a intervention. It's originally a skip for families of kids with cancer. And so there's a psychoeducational intervention component with a CBT kind of based on it to help educate both families and adolescents around their prognosis and diagnosis and coping with cancer. Coping Coach was developed for kids with acute traumatic medical events, so have an injury that lands you in the hospital, those sort of things. So across these different interventions, some commonalities are, most of them are CBT based, they're very developmentally tailored, so taking maybe what we've learned from some of the adults, but then, making it a little bit, I like to say, more fun. I am a pediatric person, so, we can be goofy. There's lots of colors, lots of trying to engage people in friendly ways. I will say in some of these interventions that our adults have seen, they're like, I want that for me. So maybe we need to kid up some of our adult interventions too. But so we're missing this in our CF community currently, as far as what do we do for our kiddos that are presenting with medical traumatic stress? What kind of resources can we create for folks? So this is early data again. For this study, we're looking at both, can we describe better what is the prevalence, how many of our kids are experiencing medical traumatic stress in current day and age, and then thinking about having our families describe, what are the things do they think are potentially traumatic? What are the things medical teams could do to help offset that traumatic experience? So think about both, do we need a psychological intervention where you need somebody who is a trained mental health provider? Can we provide some basic psychoeducation and integrate that into medical teams as well, so that we're kind of shifting our care or equipping medical teams to deal with this kind of throughout treatment of CF also. So we have a two-part study, mixed methods design. And our first step, we collected data from child report on medical traumatic stress, parent report on medical traumatic stress for themselves and for their child. We also have data on anxiety and depression that we're not going to present today, but one of the reasons we collected that data is to see in our screenings of anxiety and depression, that's kind of standard in what we're supposed to be doing in all of our clinics, are we catching all the kids that would also present with medical traumatic stress, or do those assessment measures miss kids because the symptom overlap isn't completely there? So we're going to take a look at that as well. And we have flexible enrollment pathways. So we try to get people any way we could. So we have two different sites. So University of Kentucky Healthcare, at our center, we enrolled both in person and via phone, followed up with email, all the things that you do to try to get people into the studies. Our partners at Children's Hospital of Philadelphia enrolled on the phone only. And so I think that that's telling for some of the differences in results that we see as well, because we have a little bit of different cohorts, not just at the different locations, but also our methods of enrollment are a little bit different. And the second study step, we are ongoing, collecting interview data with youth and caregivers and asking about these things, asking about what are the hard parts of having CF, trying to pull out what is maybe anxiety-based, what's depression-based, what's trauma-based, and then looking at kind of what can we do about it. And then probably within the next month or so, we're going to start healthcare provider interviews too. So keep an eye out in your inbox if you might want to participate in that and give us some ideas from your own perspectives. So to give you a sense of where we are at now, we have enrolled and consented 86 child parent dyads across the two institutions. If you look kind of broadly, the numbers are approximately similar, with one of the big differences being at the Children's Hospital of Philadelphia, they have a lot more in the missed bucket, and most likely due to the phone call recruitment versus the in-person recruitment. We have identified eligibility for our interview data. We have a total of about 17 child parent dyads eligible. We've completed 4 interviews to date. I think we have about 5 more scheduled currently. And that eligibility criteria was that either the child or the parent endorsed significant post-traumatic stress symptoms for the child. And so when you look at our UKY eligibility, that's right on target as to what we expected. We expected about 30% of kids would pop positive with medical traumatic stress symptoms based on some of the adult literature, as well as what we see in other chronic illness populations. And if we look at our partner at CHOP, we only had about close to 10% pop positive. And so that piece we're still trying to sort out. Whether that might be due to phone enrollment differences, whether it might be due to something different they're doing at their site. They have had mental health services embedded longer than we have at our site. So we're not quite sure exactly what that reason is, but we're going to be exploring that with some additional participation at some other sites too that we'll talk about in just a minute here. So preliminary results, and I think one of the things to look at here is we have our youth-reported medical traumatic stress at both sites and our parent-reported medical traumatic stress at both sites. You know, we had in our history a tendency just to ask parents and get parents' opinions on this, but you can take a look at these numbers to see that there's not direct overlap. Some parents are reporting stuff that kids aren't reporting, some kids are reporting stuff that parents aren't reporting. So really taking attention to that, we need to be doing full assessments with parents and kids together if we want to get the full picture. Oh, and one other note here, our caregiver PTS, those rates are really, really low. And we're looking at our scoring. So what we scored in this measure that we're presenting right here is probable PTSD. So actual diagnosable PTSD rather than significant symptoms. And so we are going to be adding the other scoring too to look at significant symptoms in caregivers as well. So we expect that those significant symptoms will be higher also. So I just provided a few sample ideas and quotes from the interview studies that we have been doing. We've not been able to collect enough interview data yet to do systematic coding. So this is all preliminary ideas that we think, will help us inform where we're going next. But just a number of comments around kind of that feeling of being different, feeling about some of them. In this, oh my gosh, this just kills me. The making fun of kids for having medical. As a clinician, it just drives me crazy. Kids can be mean. But just thinking about, some of that's popping out and thinking about where does that fit in the way that we take care of our kiddos. From our caregivers, one of the things that I think has popped in, we are also partnering with the Community Voice Committee as well, is around that understanding it's an invisible illness. So it looks like everything's fine from the outside, but then sometimes these kids are carrying really significant burdens of things. All that piece of that unknown and not knowing what direction things are going. Some of the things that I also think we often don't think about, particularly in pediatrics, is some of the other consequences or challenges with CF, such as fertility. So some of the things that our kids aren't thinking about, not sure how many medical teams are doing education about that early, but some of our parents, that really popped for them. So some sample topics that we think might pop into an intervention eventually. Again, we have to sort out which of these might be anxiety, depression related versus which might be specific medical trauma related. But things about general worries about having CF, fears about their long-term health outcomes, procedures, and there's been some amazing work on procedural anxiety over time here. Treatment side effects, constipation came up a lot so far. Again, we only have 4 participants, but that one just kind of surprised me a little bit because I didn't have that as top of mind about that being so challenging for folks. And then navigating traumatic stress reactions during routine medical care. So when they're in for care and they're having symptoms, figuring out, how do they do that? The normative sicknesses too, again, with the landscape of COVID really shifting that to we all are more afraid of going to school for sicknesses and going to work and going to these conferences. I felt really weird. This is a lot of people in here. I'm like, oh no, should we be, I'm like, how am I going to get home and not be sick? I just am so convinced. You guys can all follow up with me later and see, is my cognition, I don't know, not really rational, but it's there. And you think about for these families that have that chronic piece with them, what does that look like for them? Some ideas around other things that popped up, quality of life challenges, manning those unexpected hospitalizations. We've seen a lot of those decrease, but they're not eliminated. We still see a lot of kids popping in with them. Those challenges about being different from peers, people's reaction to their diagnosis as well. And then that parental guilt piece has popped up for a few of our families. Ideas and protective factors that families have shared with us, thinking about hope for the future. So I think there's been a big shift in that, especially with some of our new medications that have come out. A number of our kids said, my parents are in my corner, or my grandma, or they've got that one person they can kind of go to for their support. School nurses popped out is really supportive, and I know depending on the community, access to school nurses might be stronger or less strong, but thinking about partnerships and thinking about the schoolwork that Stephanie's and her team has done, if we can figure out how to engage the school, that might be another avenue to support. And then again, support from the medical team. And so this popped out a lot, that how supportive medical teams can be. So when we're thinking about our mental health interventions, not thinking about them only as social workers, psychologists, child life specialists, but also as the whole medical team. What is the role for the whole medical team in supporting our kiddos' mental health? Strategies that kids and families had shared. I think this was from a teenager that said, I think you should consider mental health. It's important. And they feel like it's actually forgotten about. So even in our kids, those kinds of comments are popping out. So just thinking about mental health, making it normative part of our assessments and normative part of our support. They recommended about exercise, figuring out how to connect. So I know you had talked about doing a group and connecting, and there's that big barrier to connection with teens, especially with CF. Thinking about how do they get access to medication for mental health. So that was an identified barrier and desire for some of our families. Then some specific ideas. It's we need to support stuffed animal. We want to, create a motto. So some very specific ideas as well. So just a quick minute wrapping up here, things that we've learned. This research is still underway. We are actually going to be starting to collect more data. We have a couple referring sites. So we're going to, because of our discrepancies in our rates of MTS and our desire to be able to conduct more interviews as well, we have a couple of sites that are now going to refer some patients to us so we can look to see, do those MTS discrepancies in how common it is kind of hold when we bring some other sites in, or is there something unique going on? Recruiting for interviews has been harder than expected. We actually took a pause over the summer and then just restarted after we got settled into the school year a little bit and had a lot more success getting things scheduled again. And the other consideration is the MTS assessment tool that we're using is not tailored for CF specifically. And so we are working and considering, what's out there now. I know a couple of colleagues that are working on this, so that might also help us over time to better capture specific to CF. What does that look like? I think I said all those things. All right, awesome. I think that also wraps that up and wraps us all up.
Thank you, Megan. That was a really strong presentation. And yeah, medical stress, I think all of our patients have had some sort of iatrogenic medical trauma. I'd also like to say before we start questions, we have plenty of time for questions. So hopefully we will get through those and get you in those lunch lines not too late. I just wanted to say that I was really honored to be among such a group of, dare I say, badass clinicians and researchers geeking out over here. So I will hand it off to Rebecca, who will lead us in the Q&A.
Okay, we do have a lot of questions on the app, but you're welcome to come up to the microphone and ask questions as well. I'm going to try to go back. I'm going to try to group some together because there were some similar ones. And for Dr. Bathgate regarding the CALM intervention, there were a couple of questions about the inclusion and exclusion criteria. There was a concern that minorities were excluded and possibly people with more urgent support were excluded at the beginning. And then if there was a plan for another trial with more inclusion.
So I really appreciate that question, and whoever, if you feel comfortable raising your hand, thank you for having the courage to ask that question. Yes, thank you. It is something that has been on my mind as well. And my colleague, Dr. Frida Liu, I don't know if she's still here, she's sitting on the floor. This is something that we talk about a lot of who is not at the table. And as I alluded to in a new grant that we are putting out, we need to have those people at the table. And so to go back to the CALM intervention, part of the intervention were materials that were sent home with the participant. It was this beautiful participant workbook that the therapist and the participant would work through together. And the funds only allowed for English. And we wanted to make sure that we could test this in a very rigorous way. Next steps, though, are to hopefully get funds to translate this into Spanish, translate this into French, translate this into other languages that clinicians might feel comfortable. Talking with some of my colleagues in Germany, if this grant were to be funded, we would be able to do those things. We would be able to offer translation services to patient-reported outcomes. And we really do encourage therapists to use CALM with whoever you want at this point. Now that we've shown that it is something that can be effective, use your translators at the hospitals. Reach out thoughtfully. Recruit those persons in your clinic that are historically marginalized persons with CF. Those are people that are racial, ethnic minorities, sexual and gender minorities, people of low SES, the people that perhaps are not always at the table in these initial studies. So I applaud you for asking that question. That was not a question plant, so I'm so grateful for you. And I guess regarding the second thing about, you were saying how to adapt. And are there plans?
There's actually several questions like that for you about children and adolescents and then group settings.
Yeah, so I was jotting down some notes. I did see that in there. I think it would work great with small groups. I mean, again, this hasn't been tested empirically. I'm thinking about 6 to 8 people, so it gives patients an opportunity to share their experience and hear from one another, give ample time for different perspectives. I could see it being adapted for lung transplant populations. Somebody in here had asked about that. I worked in bone marrow transplant for a while, and we always had this caregiver day about the do's and don'ts for when your loved one is going through transplant. And I could see CALM being a great add-on for a couple hours where you could deliver these skills to a large group format. You could also do it in a group format via telehealth for individuals too. So A lot of the materials in Calm can absolutely be adopted. The skills play well with many different groups. I think some of it is just coming up with some of your own cultural adaptations for the population you work with the examples that are given. We've got a section on what would you prefer versus saying what you don't want, right? Like everybody can say what they don't want, but being able to speak up and say what you do want, right? So somebody with lung transplant, they might say, I really don't like having to ask help from you every time I need to get up and go on my walk. And so instead of saying that, you would give them an example like, I prefer for you to come on my daily walks with me unless I specify otherwise. And let's just make that happen. So those are just some examples that I came up with. And if you want to talk more about this, poster 542. And yeah, I'm happy to share more.
There's also a question about how much training was involved for practitioners to implement the intervention.
We can do the training in, again, it's 6 sessions and a booster. I can do the training for you in 3 to 4 hours.
And if suicidality improved
In terms of reducing
severity on answers
yes.
to questions.
So at baseline, I think you guys saw that red box. It was 10% of our population. I texted my statistician to see if she could run the significance levels, and she's in a carpool line, so she can't do it right now. But we did have alerts that came up every time somebody reported a 1 or above on Q9, and both of us concurred that over time, we were just not getting those alerts anymore. And so while I can't speak to the statistical significance, I can speak just on an anecdotal level that absolutely they were going down.
And then we had a number of questions come in for Dr. Yetwin regarding the ACT group. It was asked what time of day you found worked best for the group, and if all the participants were female, and if there were male participants that were interested.
Thank you so much. Yeah, those are great questions. So it just happened that the participants in this round were all female. We did have interested participants that were male, or at least their parents said they were interested. It's unclear how much the youth actually were, but the age range didn't fully match up with what we launched. And then, sorry.
The time of day.
Oh, yes, time of day. Okay, so honestly, just trying to figure it out with my schedule and their schedule. We launched the group at 4 p.m. on Mondays, 4 to 5. We just did an hour too. Everyone has a lot going on. And I think that worked out pretty well. It was kind of good because it was like after school had ended and before some extracurriculars started. But of course, also kids would get into different activities, and there would suddenly be like a musical, and now they had rehearsal every day. So you never know, but that's what we had started with.
Was billing as group therapy or health and behavior group therapy code possible?
Yeah, so that's a great question. So the issue, maybe some hospitals out here could give us some great information, but our hospital is still figuring out all the billing for the psychologists. I think that is still kind of a work in progress. And so it seemed like it was going to be challenging, and we wanted to get this started. And so fortunately, we had this donor fund that we could rely on. But yes, that should be an opportunity. The other issue was we had participants with different types of insurance. And so, when you're thinking of equity and what if we're charging these people, but we're not charging these people. And so that's where it became complicated.
There was a comment that your flexibility during the treatment implementation was appreciated. Going forward, do you think there was a way to build this flexibility into the treatment manual?
Yeah, I think that would definitely be possible. I think, like I said, we were just kind of letting the participants guide us and going along with what worked for them. But I think there's definitely a lot of opportunity there, and more stuff that can be done. We were just kind of throwing stuff out there, seeing what they liked. But I think that's a great idea.
And one final question for you at the moment. Did participants opt to exchange contact information with one another? And if so, how did you handle?
Yeah, great question. I think 2 of them did on the side. I didn't directly address that. But yeah, it can be kind of a tricky thing to, I think, figure out and maneuver. So something to keep in mind. But, the way I look at it is like they don't have those opportunities to really hang out together and go grab a coffee and well, maybe not coffee, but go grab some food. So I think it's great to let that be possible if you think it's appropriate.
A lot of questions about procedural anxiety and medical traumatic stress. There were a couple of questions asking what medical traumatic stress assessment tool was used.
So we used in this study the CATS and the PCL. I think Dr. Cunillo has a new medical traumatic stress tool that is currently under validation, but was not quite ready when we started. So hopefully we'll have access to that moving forward also.
And then there were a couple of questions about procedural anxiety interventions that might be recommended specifically for children with low cognitive functioning or sensory issues. And then also a comment about if Dr. Marsak, if you've seen kids with medical traumatic responses, if those kids have reduced comfort with physical touch.
Do you want to talk about that? Okay.
Sorry. That was confusing.
So I think, yes, depending on how their symptoms come out, right? So for some kids with trauma reactions, they get more withdrawn and more jumpy. And it also depends on if they're having medical traumatic stress, do they also have other trauma in their community? So something we always also are aware of is that a lot of our kiddos coming to us have past trauma, other trauma, might have abuse or sexual abuse or whatnot. And so kind of depending on what their symptom profile is, they definitely could have discomfort with touch. We've got other kiddos that get really clingy and it goes the other direction as well. So it can kind of go either direction with medical traumatic stress.
And then for the interventions, so chaining is really great to use. And so you want to build skills. So you're going to start with, again, your modeling. And so you want to do like a repeat type behavior. So if you're asking, let's say for a swab, you're going to give very simple directives. And so we're going to say, okay, we're going to do a swab. We're going to practice open your mouth, right? You're demonstrating, you're modeling. The kids usually will follow you of any cognitive developmental age. They can mirror your behaviors. And so one of the sweet tips that we had from a mom, again, this was like someone was asking, okay, are you ready? Can we do a swab today? And the kid was, no. And every answer was no, of course, to every question. So, right, you need to think about, okay, so what do I need to say to help this person understand what's going to happen to them today, right? And who can be involved in helping. And so clear, simple instructions are the best way to go in those situations with the modeling.
Thank you. There was a question for both of you also about the differences between procedural anxiety and medical traumatic stress.
I think that there's some overlap. I think that sometimes if procedural anxiety is left unchecked, then it also, I think, can swing into that trauma where you're having like more symptoms leading up to things versus like procedural anxiety. Often we see a little bit closer in the moment. And when it's done, it's done. With some of the trauma reactions, sometimes you don't see that as much. And I think if you can address some of the procedural anxiety while it's at a lower level, sometimes you might be able to prevent actual trauma kind of cognitions and stuff from settling in. But there's definitely some overlap. And I think some overlap in the way you treat it. We do a lot of this similar cognitive behavioral strategies around that as well. So I think there's definitely some overlap. Do you have other thoughts on that?
No, yeah, absolutely. When it's unchecked, like if you're not providing those procedural anxiety interventions, it can develop into a traumatic situation. If you can just envision like having a child having to be held down repeatedly because of their stuff, right? Like that's traumatic over time. It's too much.
Similarly, there's a question about how do you work with parents who feel like they have tried everything for their child's procedural anxiety and feel hopeless that nothing will work?
Well, I do think, right, like we want to give them the hope back and we want to let them know that some things are developmentally appropriate, right? Like it's okay for a kid to feel scared. I would be more surprised if they weren't afraid sometimes of some of these things that are happening that do in fact hurt, and so helping normalize the behaviors with the parents is good, but then also reminding the parents, you have the toolkit. We're gonna keep going. We're here to support you as well. Checking in on that parental anxiety. Sometimes I think they're really nervous about it as well, right? Because they know this has not gone well. And letting parents know, again, it's okay for your kid to cry, right? But that's sometimes why I measure how long they cry, because I've noticed with these interventions, the crying reduces as well. I'm like, oh, look at the first time that they did this, they cried through the whole visit. This next time, they cried for about 5 seconds, and then the next time they didn't cry at all, right? So letting them know there is progress, but sometimes parents have some expectations for instant change, right? And so we just know that it takes time.
And there was a question about what would you say the difference is between positive behavior supports, like you mentioned, and parental bribery?
Positive behavior supports are instantaneous rewards that encourage the behavior that we want to see to keep happening. So a bribe is when a parent is like, if you do really good, we're going to go get ice cream, but if not, no ice cream, right? And so one, what does good mean, right? They can't provide any positive behavior supports in that moment of the desired behavior when it's seen. And it's contingent upon them getting, right, from the parent, it's contingent upon something ambiguous. It's not really helpful. So we want to make sure that the undesired behavior is also not getting rewarded, right? So if they have anxiety around, let's say, a swab, and we're not doing interventions, if I just say, you know what, this is too traumatic for you, we're not going to do it today because you're crying. I've just rewarded that behavior, and then next time they're going to keep crying and keep crying and keep crying. So they know what to do in order to avoid a swab. So we're doing things like that, but we also want to help the parents understand. I had one parent who just kept throwing things out okay, if you do the swab, we'll go get ice cream. Okay, if you do the swab, we're going to do this. Okay, if you do the swab, this is going to happen. Don't you want this to happen? And I was I need you to just stop. Just stop. You're making it worse.
That helps. Does anyone else want to?
There's one more for you. How did you get the entire pediatric team on board with assessing for anxiety during patient visits?
Bribery. No, I'm just kidding. I'm just kidding. We have honestly, we have a really supportive doctor who helps rally the troops. And so, and our psychologist is also a gung-ho kind of lady. And so it really helped to say, when I want to do something, for them to be yeah, let's do this. And that's kind of the motto of our team that we've built over years, which has been really great. But the really cool thing is, we had clinic on Monday and I missed it because I was here. And the whole team was able to continue going with the procedural anxiety. Because the whole team is trained now and knows how we do this, and we've set those steps of this happens, this happens, this happens. Anyone can fill in and take those roles, and it's been super helpful. So it's been a labor of love to get everyone trained and keep going and keep it on their minds and remind them this is what we're doing, remember, but they're all on board.
Thank you.
And if they're not, no positive behavior supports for them.
Dr. Marsak, there's a question. Medical traumatic stress carries over to other settings such as the classroom. What tips or steps would you recommend to help support kids in the classroom with medical traumatic stress?
So I think whenever we are treating that or aware of that, partnering with the school, seeing where the behaviors are coming out and making tailored plans for kids. If the parents are comfortable with involving the school, we do partner often with school counselors as well, of if that's a positive thing in that school. It's not always, or finding a champion teacher, finding one adult that can help with some of that as well. And so really creating your partnerships and then figuring out what are your interventions that they're using in the clinic, in your clinic, and then how do those carry over and how could they be modified for a school setting?
Okay, and then there's just a couple of comments. If you're looking for the school toolkit QR code, you can come to poster 555. and the QR code is on the poster. And then Dr. Foligno shared that a reminder that there are also procedural anxiety resources on mycff.org from a previous mental health special course. So you can email mentalhealth@cff.org to get access.
Can I say one more thing about the toolkit? I just realized that I didn't say explicitly. We had one of our pilot centers hand the toolkit to a family. I want to be very clear. The toolkit was designed for care teams, and that there are things that can be shared with the family in terms of handouts. The toolkit was not designed for families. It wasn't written that way. So just to make sure that, I know we all pull things out of a tool, not an actual toolkit, but we have our resources and then we hand it to families. I just want to be very clear that when you're utilizing the toolkit, it is designed for us as care providers, but there are some websites and handouts that you can give to family, but the toolkit is not designed to hand to a family.
And there was a question about materials being available in Spanish that I think was for you, but I'm not positive. If anyone wants to clarify, if you asked that question. But it's good to know if you want to answer it.
Yeah, so some of the tools that are in the school toolkit are developmental roadmaps that are around education that are included in the toolkit that are translated into multiple languages. Of course, this again the inclusion is extremely important. And so if there are things in the toolkit that you would like translated, we need to be thinking through that together about how to do that. We don't want there to be any stop signs for us. We want to make sure that everyone has equal access to this information and the tools.
I think we hit them all, so we did it.